Good morning. I'm Peter Stanton, publisher of the Worcester Business Journal, and it's my pleasure to welcome you to our 10th annual Central Mass Healthcare Forum. This annual gathering of industry leaders has produced entertaining, informative, and at times riveting conversations about the future of the healthcare sector in our region. And I expect this morning's conversation will live up to that high standard based on our keynote and the all-star panel we have with us today. Making this annual healthcare forum happen takes a lot of effort, and we appreciate the support we've had for years from our event partner and presenting sponsor, Fallon Health. The Fallon team has not only supported the event, but been a think tank partner when it comes to picking timely topics and identifying top speakers. I'd also like to give a special thanks to our corporate sponsors, Always Health Partners, and our media partner, GBH. At this time, I'd like to give Fallon Health's Senior VP and Chief Communications Officer, Christine Cassidy, the opportunity to share some welcome comment remarks. So Christine, it's all yours.
Good morning, and thank you, Peter. Fallon Health is proud to once again be the presenting sponsor of the Worcester Business Journal's annual Central Massachusetts Healthcare Forum. Thank you to Peter, Chris Prosser, the Worcester Business Journal team for creating this opportunity, bring us all together to hear from local healthcare leadership and to explore the topic of disruptions and innovation, both of which have been front and center in many different ways over the past decade or so. I first started working in the health insurance industry at a time when it seemed less complicated and a bit more predictable. Clearly, that's no longer the case. Much has changed and continues to change. And based on all that's happening, there's much to talk about this morning. The past 2 years have been completely different years than anything most, if not all of us, have ever experienced. And it's tested us in one way or another. Being a mission-driven organization has served Fallon Health well during this unprecedented time. And we've worked very hard, often alongside other stakeholders, to respond quickly to the evolving and diverse needs of our members and the community, while also ensuring the health and safety of our workforce and the continuity of our business operations. It's been challenging, but we continue to focus on the work we need to do in support of Fallon Health's mission. And we look forward to opportunities such as today's forum to help us prepare for the future so that we can continue to help shape the local healthcare landscape. On behalf of Fallon Health, thank you again to the Worcester Business Journal, and thank you all for joining.
Thanks, Christine. And now it's my pleasure to introduce our keynote speaker. Dr. Jonathan Gruber is the Ford Professor of Economics at MIT. He recently served as the Director of the Healthcare Program at the National Bureau of Economic Research, and is the former president of the American Society of Health Economists. He was a key architect of Massachusetts' ambitious health reform effort, served on the Health Connector Board. He also served as a consultant to the Obama administration and worked to help craft the Patient Protection and Affordable Care Act. In 2011, he was named one of the top 25 most innovative and practical thinkers of our time. Interesting combination, innovative and practical. Sometimes maybe they don't always go together, but a powerful combination, and that was by Slate Magazine. So needless to say, we're very pleased to have Dr. Gruber joining us this morning. Jonathan, it's all yours.
Thank you very much, Peter. And it's great to be here, albeit virtually. I hope we can all get together in person at some point. But for today, this is a great start. I'm going to talk for maybe about 15 minutes about some issues in the state of healthcare in the US, and then I'd love to have a few minutes for questions before the panel kicks off next. I want to cover really sort of a couple of topics. The first topic is, where does the Affordable Care Act stand right now? We've had this roller coaster ride of an act which passed, which was very successful on the policy front in the early days, but an utter failure on the political front, which then came within a thumbs down of repeal, but has survived and is in pretty good shape. I would say the Affordable Care Act today is pretty close to where it was before, pretty close to where it was a few years ago. We're probably covering around 20 million Americans that wouldn't have been covered otherwise with healthcare. The exchanges are all stable and functioning. There's been no death spirals within the exchanges. They're working well. Premium growth within the exchanges continues. But remember, there's only two things that are always true in life, right? Which is baseball games take too long and healthcare premiums go up. So healthcare premiums continue to go up, but they're going up at a slower rate than they were before the exchanges were introduced. So I think things are pretty stable. The question is really what happens now? What happens now partly depends on what happens with President Biden's Build Back Better initiative. That includes significant funding for the Affordable Care Act, in particular in a couple of areas. First is to continue the short-term expansion of tax credits on the ACA exchanges. If you recall, the original structure of the Affordable Care Act was people could get tax credits to buy health insurance on the exchanges, but only up to 4 times the poverty line, or about $100,000 for a family. The American Rescue Plan took that cap off, extended those subsidies so that all Americans could get health insurance on the exchange for a maximum of 8.5% of their income. The president's plan but the ARP provision expires after a year. The president's plan in the Build Back Better Act would extend those subsidies so that all Americans could access the exchanges for no more than 8.5% of their income. So that's part of what folks are voting on now. The second piece in that act that's probably most important is dealing with the recalcitrant and really states that have engaged in political malpractice by not expanding their Medicaid programs. Remember that due to a Supreme Court decision in 2012, states had the choice of whether to allow the federal government to pay to cover their low-income citizens. I mean, it really is sort of crazy when you think about it, right? Basically, if you take a state like Florida, Florida has 1 million uninsured individuals under the poverty line. The federal government is coming and saying, we will pay 90% of the cost of covering those people, which by any economic model, if you take the injection of federal funds, is more than worth it for the state of Florida. Their 10% share is dominated by the other benefits to the state. And yet 12 states have still not expanded their Medicaid programs, including places like Florida and Texas. So the other piece that would be in the Build Back Better Act would be to actually allow individuals in those states who are below the poverty line to get into the exchanges, which they're currently excluded from. So right now we have this odd situation where if you're in Florida and you live at 1% below the poverty line, you have no access to healthcare. If you're 1% above the poverty line, you can get healthcare very cheaply. In the Build Back Better Act, they would improve that by basically saying everybody in Florida can get access to the exchanges, and in particular, everybody in these states that have not expanded Medicaid. So these are important changes, which put together would add several million people to the ranks of the insured. Really, most importantly, I think the second provision is more important because this would take very low-income people who currently have no option to get health insurance because they're not eligible for Medicaid, they can't get subsidies on the exchange, and bring them into the pool of the insured. I think if this bill passes, we'll end up with the effect of the Affordable Care Act being close to what was originally projected. The original CBO projections as of 2010, where this act will cover about 27 million Americans. I think if we can get these provisions in place, we'll probably get up to about 23 or 24 million Americans covered, which is great. That's a huge step forward, but it's less than half the uninsured. Let's be clear, this is not moving us to universal coverage in a sense of the word. It's a huge dent in the number of uninsured in America, but it doesn't, quote unquote, solve our problem of universal coverage. So what's left that needs to be done? Well, part of the problem is just political, fundamentally political, which is that basically about a third of the remaining uninsured American are undocumented immigrants. And there's no appetite for covering undocumented immigrants in our political system. So we're never going to get to 100% coverage. That's never going to happen. But that doesn't mean we can't get to closer to 100% among documented residents of our country. And the way to do that is to take advantage of lessons from behavioral economics. To realize that many people in America are eligible for very affordable health insurance and simply aren't aware or can't be bothered to enroll in it. And here we can take lessons like, for example, auto-enrolling those who have free health insurance in those plans. Why can't, for example, the state of Massachusetts on our tax form say, hey, we see you're uninsured. We see you're eligible for free health insurance coverage, which probably more than 100,000 of the uninsured in Massachusetts are eligible for. We're just going to, unless you check a box saying you don't want it, we're going to auto enroll you in health insurance. That would bring many of the low income individuals who currently don't realize in many cases they're eligible for free health insurance coverage into the system. There's other things we can do. We can make health insurance choices easier to make. Health insurance choices can be confusing. By my estimates from my research suggests that only less than 20% of people who choose a health insurance plan choose the lowest cost plan that's available to them. Most people haven't figured out how to choose the lowest cost plan available to them. We can make choices easier to understand, and we can basically make the health insurance selection process a lot more pleasant. I think auto enrollment, improving choices, and other nudges of that type can really take us a long way towards addressing that remaining problem of the uninsured. So the bottom line in insurance coverage is the ACA has been a big success. If we can add the pieces that are missing through the Build Back Better Act, we'll make it even more of a success. And then the next step, I think we've sort of at that point will have exhausted our government appetite for big new expenditures to cover the uninsured. At that point, it's about taking our structure and making it work better for people, using some of these lessons of behavioral economics. So that's where we're on coverage. What about healthcare costs? Now that we're sort of made a lot of progress on coverage, we've got to turn to the next big problem, which is out of control healthcare costs. Now, healthcare costs, the good news is healthcare costs from 2010 till a couple of years ago grew at the slowest rate in measured history. They grew, like I said, they always grow, but they grew at the slowest rate in measured history. The problem is the rate of healthcare inflation is picking up again, and we're going to have to address this. And I think what we've learned is that really the private market is not capable of addressing the underlying high cost of healthcare. Basically, we've tried many different ways to try to introduce competition in healthcare sectors. We've tried accountable care organizations. We've tried all these different wonderful acronyms, and they're simply not working. And that ultimately, we have to realize that this is a place, while we may believe in American exceptionalism, the fact that we are the only country in the world that does not regulate its healthcare prices probably means we're getting something wrong. And that it's time to think seriously about more aggressive government regulation of healthcare prices. That this is a market where competition is not working, it's not bringing prices down, and we need at least some degree of more aggressive government regulation. Now, a natural place for that to start is the most transparent price on our healthcare system, and the ones people are most upset about, which is the price of prescription drugs. Prescription drug prices are many multiples in the US what they are in the rest of the world. We are once again the only country in the world that doesn't regulate our healthcare prices, or at least allow government to negotiate healthcare prices. And so a natural first step on regulating healthcare is to think about regulating the price we pay for prescription drugs. That has been a debate that's right now taking place in Washington. Originally, a major source of funding for the Build Back Better Act was going to be aggressive regulation of prescription drug prices. In particular, the Secretary of the Health and Human Services was going to be given the regulatory power to negotiate drug price on behalf of the government, to bring the government's purchasing power to bear to negotiate lower drug prices, with a backstop that the US drug prices could not be more than 120% of the weighted average of the price in other countries around the world. And that has basically died. That idea has basically died. The idea of essentially outsourcing our regulation to other countries wasn't very popular, and that is dead. Right now, there is still some discussion of much more modest drug price regulation. In particular, once again, giving the secretary negotiating power of a very small set of drugs and allowing the secretary the right to negotiate those, and then trying to set benchmarks to sort of constrain that. The other issue that's being debated right now is, should we limit the price growth of drugs? Should we say that drugs are on the market can only grow, their price can only grow at the rate of inflation? I'm sort of less impressed with that as a solution, because if we put that in place, drug companies just raise their launch prices. You know, it's not clear. If you say to drug companies, in the future, you can't raise your prices more, they'll say, fine, we'll just raise our launch prices. So I think that basically more aggressive tools of regulation are going to be needed, but it's hard. The political challenge is hard. And now, we move beyond drug companies to other providers like who are involved in this call, in this conversation. We're going to have to think seriously about what we do about regulating and limiting the prices paid to our doctors and hospitals. Because right now, those prices are too high and grow too fast. And we're going to need to think about how we can do that, trading off ensuring sufficient access with limiting the rate of cost growth. Here's the good news, though. It seems like a politically daunting task, but here's the good news. We don't actually have to lower the cost of healthcare in America. We can afford, I know it seems like healthcare costs are very high, but look, right now, we can afford the costs we spend in healthcare. We just can't afford them to grow so fast. So the good news is we don't have to go to healthcare providers and say, we're taking a lot of money from you. We just have to simply go to healthcare providers and say, we need to figure out a solution so that your costs don't grow any faster than the rate of economic growth. We spend 18% of GDP on healthcare today. If we're spending 18% of GDP in healthcare in 50 years, it'd be heroic. We're in great shape. But we can't afford to be spending 30% of GDP on healthcare in 50 years. And that's the challenge that faces us. Let me just end by raising one other issue that's coming on the horizon that I think we need to pay more attention to, which is it's always easy to say, gee, we should pay less for drugs that don't do much good. The question is, what about the challenge of the new revolution of incredibly expensive but incredibly effective genetic treatments? We are now on the verge of discovering treatments for diseases once considered uncurable, like sickle cell anemia, like cystic fibrosis, that like type 1 diabetes, if you read about that in the paper last week. Through genetic cures, we may actually be able to cure these endemic diseases, which are once considered uncurable, but at an incredibly high price. That is a challenge because those prices are actually worth it. If we have a disease, if we have a cure for type 1 diabetes, it's worth $2 million to pay for that. The question is, how are we going to afford that and how are we going to pay that? So we have a coming really important debate to be having about these oncoming incredibly expensive, but incredibly effective life-saving treatments. And we just start having that debate now because the treatments are coming. My assessment with my colleagues is that if you just look at treatments that are in the pipeline as of a year ago, this doesn't count the new type 1 diabetes treatment that's starting to enter the pipeline. Look at treatments in the pipeline as of a year ago. Over the next decade, we'll spend $300 billion on genetic drugs alone, genetic treatments alone, $300 billion. That's without considering all the new drugs coming in the pipeline. So we need to start taking this issue seriously and addressing the advent of these very expensive but yet very effective treatments. So bottom line is, on coverage, we're making progress, but we need to pass the Build Back Better Act and the provisions in there to really get to the full potential of the ACA. And then we're going to need to keep working to try to increase coverage. On costs, I think we've just seen that increased competition is not solving our problems. We're going to need more regulation. The question is how we get the political will to do that in a smart way. So that's very quickly the state of where we are in healthcare in the US. I hope I've been sufficiently controversial that I've generated a few questions that we can spend about 10 minutes answering. Thank you.
So we've got a Q&A box in the for all the participants, and we can wait for some questions to come in. I'll start though with one, Dr. Gruber. Why is the government been so hesitant to put price controls on the pharmaceutical industry? Can you sort of describe that, the pitch of that battle, and why it's just been so politically difficult? Obviously, it's lobbying money, but
well, yeah, I mean, the answer is simple. It's pharma. It's lobbying money. Now, to be fair, there is a legitimate concern that in some sense, the way the drug sort of world works right now is we overpay for our drugs in the U.S. The governments take the companies take that money, plow part of it back to R&D, and then that R&D creates better drugs for the whole world. So the drug companies legitimately argue, gee, if you cut our prices too much, that'll cut our R&D. However, what they're missing is that much of the R&D that really helps is actually government funded. Look at the coronavirus. That was government funded R&D. By my estimates, I have an article in the New England Journal of Medicine that just came out with my colleagues Rena Conti and Richard Frank. We've estimated that if the government were to regulate drug prices and take less than a quarter of the money it saved and put it back into NIH and other supports of government research, we could actually increase innovation, not cut innovation in the US drug sector. So the drug companies make an argument that we'd hurt innovation. The answer is yes, potentially if we cut drug prices, innovation might fall on the private side. But by just putting a small fraction of that into places like NIH, we could overall increase innovation in drugs. So really, there's no reason not to do it other than politics.
Got it. Do any of our panelists or attendees have a question? I don't see any in the Q&A just yet. And if any of the panelists want to jump on and comment on that would be great. Richard?
Yeah, I have a question for Dr. Gruber, and that is what do you think in Massachusetts are some of the more promising initiatives or ideas or ways to control healthcare costs?
Yeah, I mean, Massachusetts, we did pass a big law a number of years ago, which sort of nominally constrains healthcare costs to rise at the rate of state economic growth. That law has in some sense worked in that healthcare costs haven't, but I think that's more by historic accident than reality. I don't think that law has a whole lot of teeth. I think that it begins, quite frankly, with antitrust enforcement. We've learned that basically mergers in the healthcare sector are cost increasing. There's no doubt about it, or at least are price increasing. I don't know if they're cost increasing, they may be profit increasing, but there's certainly price increasing for consumers. So it starts with much stronger, no more mergers in the health. I'm not saying it's easy to break up existing mergers, that's water under the bridge, but we've got to basically, really reduce the ongoing consolidation in the healthcare sector. That's point one. Point two is we need to think about how we add teeth to price regulation in the state. We need to think about, once again, and I'm not saying that we need to cut prices. I'm saying we need to think about how to add teeth about constraining price growth in the state, about actually limiting the rate at which healthcare costs can grow. And I don't, Richard, it's an enormous political challenge, especially in a state where healthcare is such an economic driver. But I think we need to recognize that it's overall good for the economy of Massachusetts if healthcare costs grow more slowly, and that we can do so in a way which doesn't hurt employment in the healthcare sector. We need to recognize that if we can lower costs, if we, for example, a simple example, if we have more of our healthcare delivered by nurses rather than doctors, that creates jobs and lowers costs. So we need to be thinking about a way that we can essentially broaden the employment base in healthcare and lower the cost of delivering it. Peter, if you're talking, you're on mute.
All right, how's that? There is a question that came in from someone in the audience, and the question is, what are some of the other cost drivers for healthcare costs beyond drug prices, sort of the larger ones that could be addressed in a novel or disruptive way?
Yeah, I mean, I think, where health economics is really centered over the last decade is, the old quote that's attributed to the famous late health economist Uwe Reinhardt, which is, it's the price is stupid. That basically, it's about healthcare prices. That basically, really, we can try to do lots of novel things, like I said, like ACOs and other kind of initiatives. I think narrow networks have actually worked a lot to help slow healthcare costs in a good way overall. But ultimately, we've got to regulate, we've got to lower the prices that are paid, because right now all the price incentives are to deliver more and more expensive care at higher and higher costs. And basically, I think that really starts by essentially saying, what are the services that really are being delivered that are actually not, that are being delivered at very high costs. They can be delivered at much lower costs at other locations. If you look at the data from the state on the variation in prices for things like appendectomies or things which are pretty low tech in services, there's huge variation over the state. Why aren't we enforcing that people should go to the low cost providers for things like appendectomies? Why are we allowing people to go to very high cost providers for things which are essentially commodifiable healthcare services. So we need to really, and it's not, once people say, oh, fine, we'll provide information, let people shop. That doesn't work. Okay, the information's hard to read. People aren't good at shopping. We need to do that in more aggressive ways to actually get people to go to lower cost providers and to bring prices down in that way.
Sounds good. Here's one more question that just came in. Can you comment on the move to value-based healthcare and the impact this will have on the cost of healthcare? Is this going to be a factor in bending the cost curve?
Yeah, I mean, value-based healthcare is wonderful vocabulary, but the truth is it's hard to carry out in practice. The idea of value-based healthcare is exactly right. We should pay for that. We should pay for stuff that works, not stuff that doesn't work. It's just been proven to be difficult to put it in practice. And in some sense, what I'm advocating would be not blind regulation, but smart regulation. In some sense, value-based regulation. That in some sense, having the private sector live with value-based care hasn't worked. What we need is really value-based regulation. What I mean by that is, look, if there is an incredibly expensive yet valuable new treatment, we should pay what it costs to deliver it. We shouldn't deny people life-saving healthcare. But when we have drugs that are no better than other drugs, and yet they cost 3 times as much, or we're delivering an appendectomy at a hospital that does no better job but charges 3 times as much, we need to get in there and regulate that that's not a choice. And so really it's value-based is the right term. But right now, I think just relying on the private sector for value-based care simply hasn't worked. And I'm sorry I sound like such a big government guy here, but it just reflects my frustration that the ACA was big on pushing value-based care. It just hasn't really done a whole lot.
Mm-hmm. So Lisa and Ken, you're both on. I don't know if you had a question or comment. We got about 2 minutes left with Dr. Gruber.
Yeah, no, I actually want to go back to a comment that he made earlier about engaging sort of nurses and others to deliver more care because they can. We're also sort of facing the collision of pipeline issues and particularly nursing workforce. So, I mean, it's a gnarly problem that we've been trying to solve for a long time, even pre-pandemic. So what are your thoughts on, where we go from here?
Yeah, I actually have a lot of thoughts on that. Something I'm working a lot is I think that we need to build a better career pipeline in the entire nursing sector. So right now, we have a lot of people who, it doesn't take that much training to start at the bottom with this to be a CNA. CNA is 1 semester part-time. You can be a CNA. But a lot of people don't want to do that because CNA jobs are hard and they're not well paid. Now, one answer would be pay CNAs a lot more. We've been saying that forever. That's not working. The other answer is to say, tell people, we will help you become CNA, and in 2 years, we will train you to become an LPN. We will pay for that training to become an LPN. And 2 years after that, we'll start training to become an RN. And RN's a really good job. So basically, we need to essentially build that career ladder from the bottom. This is something I really like to work. If folks on this call are interested, I really want to work with the state on setting up this infrastructure of really attracting people into the nursing career ladder and then thickening that career ladder from the bottom up. Not trying to bring people right into RN. I think it's too hard. I think we need to bring people. There's a lot of service sector jobs that are gone forever now. Let's take those people and bring them into the nursing career ladder. But let's make that a fruitful career ladder so that people don't feel like I don't want to be a CNA because I want to make $14 an hour. Say, hey, yeah, that's true. You make $14 an hour for 2 years, but then in 3 years, you'll start making $20 an hour and so on and so on. And you move up to having a high wage as a nurse. And I think that's really something I feel quite strongly about and would love to work with others on.
Dr. Gruber, it's 9 o'clock. Do you have time for one more?
Sure.
Okay. So his question that just came in, how do you envision disease prevention measures, especially for chronic diseases, which are obviously a big part of the cost of healthcare, such as type 2 diabetes? How does that factor into keeping healthcare costs low when you look at that long time curve?
Well, I mean, I think, chronic illness is a huge problem in America. I think that is something where, part of it is personal responsibility. We need to do more to encourage healthier lifestyles and personal responsibility, but that's really hard. It's hard because politically it's challenging to, the politics of telling people what to eat or how much to exercise is really challenging. So I think really the main thing is we need to recognize a lot of chronic disease can be managed quite easily. Take diabetes, if you take your metformin, you're in good shape, but many people don't. So I think we really need to think about how we can more aggressively manage care especially for patients who are sort of frequent flyers in the system because they're not managing their chronic illness, how it can more effectively manage care with the low-cost medicines that are available. And I think while we all would like to change lifestyle, that's harder. I think we need to recognize the easier thing to do is to make sure that people who are sick are taking the low-cost actions they can to prevent getting much worse.
Terrific.
I'm going to have to run, but thank you very much.
Dr. Gruber, thank you so much. It was a great opening, and thanks for challenging us and giving us some great thoughts to discuss in your absence.
You bet. Take it easy.
You got us well started. Thank you.
Bye.
Okay, so we are officially moving. Our moderator today is going to be Brad Kane, the Worcester Business Journal's editor, but Brad will be joining us in just a minute. I will get started with the first set of questions, but I wanted to introduce our panelists to the audience today before starting in. And they are Ken Bates, who is the president and CEO of Open Sky Community Services, Richard Burke, the president and CEO of Fallon Health, and Dr. Lisa Colombo, who is the Executive Vice Chancellor of Commonwealth Medicine at the University of Massachusetts Chan Medical School. So there they are. They're their fancy pictures on the slide. And now we go back to the live, there we go, the live portion. So the first question I would have is, there have been so many challenges in this. First of all, there have been so many challenges thrown out by Dr. Gruber that we could all comment on so much of what he said, and I think we'll get back to that. But there have been a lot of challenges and negatives of the last 2 years as we've been in the midst of the pandemic. But what is the best thing you've seen happen in your organization, in the industry, like a silver lining that has come out of this last year and a half? And maybe if we can start with Lisa, if we can start with you.
Sure. Yeah. No, you're absolutely
right.
We absolutely have seen, amazing, challenges. But the things that, from my perspective, having been involved in a lot of the pandemic response work in collaboration with some of the state agencies, we saw an amazing agility and resilience and a kind of collaboration that really wasn't common, I guess I'll say, before we really were in the throes of the pandemic. We saw, collaboration among state and federal, private and public agencies to stand things up like large-scale vaccination sites and field hospitals to manage capacity that didn't exist. And I think, that lesson that we learned on how to collaborate, I think shouldn't be lost as we, move through, hopefully at some point, the end of this pandemic. I also think, we were talking a little bit before the panel discussion this morning amongst ourselves about the fact that remote work, it's a blessing and a burden in a lot of ways. But one of the things that, we at Commonwealth Medicine have found is that we could be, extremely effective in a remote work environment. I mean, it actually allowed us to extend our capabilities and to innovate and develop new solutions in a much quicker way than we have in the past. And mostly because we were constrained by our own thinking. It forced us into this space of being, truly innovative. We also have been able to recruit, Richard and I were mentioning it earlier, recruit from a much broader talent pool, not just, local to either Central Mass or the state of Massachusetts, but we've been able to recruit really quality talent from across the country, which is now not constrained by being tied to a physical office space. We've also been able to, we hold a number of seminars and conferences during the course of a year, which, resources for organizations to be able to travel and get there, are sometimes constrained and people can't always take advantage of that. But during the pandemic, we learned how to do that in a virtual way very effectively. That opened, the opportunity for more participation, not only just across the country, but actually globally in some cases. And I think the last thing that I'll just mention, which I think shouldn't be lost, is we saw a tremendous goodness in people during especially the early phases of the pandemic response, and particularly in the response to the call to action for volunteerism. And one of the greatest examples we have from our experience was at UMass Chan, when we developed the volunteer vaccine corps, when we needed to rapidly distribute vaccines on a very large scale in a very short amount of time. And we stood up this volunteer portal and began to recruit volunteers. Inside the course of about 3 or 4 weeks, we were able to engage 7,000 volunteers, both medical professionals and non-medical professionals, to help us in various different locations across the state to deliver vaccine. That's something that I don't think we would have seen before the pandemic. And I'm sure my colleagues on the call actually have some great examples too.
Yeah. So Ken, why don't we
Yeah.
go to you next on that similar
Sure,
questions
happy to.
about the silver lining?
Yeah, the silver linings. Yeah, I agree. Thank you, Peter and Lisa, to add what you said. I think from a community perspective, I think it highlighted the strength of the relationships that existed in our communities and coming together. And the focus on health-related social needs has never been greater, and of course more important. We came together in the community to address issues that had previously really been very slow in some ways, but addressing areas around homelessness. For instance, we came together and we housed more than 70 individuals in the city of Worcester with many, many partners in such a short period of time, including students and families in the Worcester public school system, that we just didn't have both the funds, the incentives, and the crisis just wasn't there. We've also helped in the area of people in the justice system. So people coming out of jails and prisons during COVID, of course, there was a big push to have people leave those facilities. We came together with many community partners to support those people and make sure that the public safety was addressed, but also public health was addressed. So there's one silver lining, it's just the relationships. I would add, though there is so much work to be done, we've not talked as a society as much about mental health as we have in the last 19 or 20 months. And so the discussion, the focus, the focus on stigma and education and the importance of mental wellness, again, I think is a tremendous silver lining. Understanding, and I'm sure we're going to talk about this as we move forward, that there are tremendous issues with regard to access in behavioral health and mental health care in particular. But the dialogue is there, and I think that's been a silver lining.
Terrific. Richard.
Yeah, I'm not sure there's much I can add other than to say, for me, I was really inspired by the frontline healthcare workers and the way, nurses, doctors, and others stepped forward and responded and put themselves, at risk to take care of our community. And for me, that was probably the most inspiring thing. In our organization, we take care of many frail elders in a number of ways, but in particular through our PACE program, Summit Elder Care. And our staff there converted our day center into a 24/7 infirmary so that COVID positive frail elders who were being discharged from the hospital because they didn't need the hospital level of stay anymore, hospital level of care anymore, could be taken care of 24/7 in one of our centers. And we made it, and really that staff made it possible for those frail elders' loved ones to be with them while they were being cared 24/7. And that made enormous difference in the lives of those frail elders and their loved ones who wanted, during that time of need, wanted to be with them. So I just think it's one example of how our community came together. Ken talked about collaboration. Our community came together in response to this, this terrible, hopefully once in a lifetime event.
Got it. So the next question is it's written as what's at the top of your mind right now. I sometimes think of that as what's keeping you up at night, is another version of that same question. In terms of what your organization or the industry needs to have right now as sort of its highest priority, is it recruitment? Is it where are you seeing sort of the number one challenge from your perch? And Rich, well, actually, why don't we start with you, Richard, and then we'll work back around in the same
Sure.
order.
Okay, thanks, Peter. Well, I think it goes without saying, healthcare is a very complex subject, I mean, I think Dr. Gruber brought that out quite effectively. So I don't think there can be a single thing that's the number one issue that needs to be tackled. But if I had to, near the top of the list is healthcare costs. And Dr. Gruber, I certainly agree with everything he said about the importance of tackling healthcare costs in our state. You know, we can be very proud that we have near universal coverage. You know, we started down that road ahead of the rest of the country. So we have great healthcare quality in this state. Quality in Massachusetts, I think, is table stakes, and everyone knows if you have high quality or if you have work to do to improve your quality. What we really have a problem with is the cost of healthcare, and it's crowding out important other priorities, whether it's in a private business that is paying more for their health insurance and can't reinvest in their workforce or in expanding their business and reaching new markets, or the Medicaid budget of the state or the Medicare budget of the federal government. It has a negative impact on our ability to spend money on education, on other social needs, on police and fire. So I think the number one thing we need to really tackle as a state is the cost of healthcare. And I think there's a number of ideas that are out there. I think the Speaker of the House put forward a bill that passed just before they went on break, Thanksgiving break, to strengthen some of the state oversight of healthcare expansion. I think that's an important bill. And I think we need to take a hard look at some of the ideas that Dr. Gruber put out there and that others have put out there around controlling what really is the constant rise in healthcare cost. I think, again, we have great quality in Massachusetts. We have great coverage. We can do more, of course, but we're very far down that road. But the sustainability of our healthcare system depends upon controlling those costs. And frankly, there are some parts of the healthcare sector in Massachusetts that need more dollars, like behavioral health. But in order to do that, some of these other high-priced parts of our healthcare system in Massachusetts need to be controlled. And probably he's right that the state is probably going to have to step in a more aggressive way to control that.
Mhm. Ken, what about from your perch?
Yeah, workforce keeps me up every night, every day, every night, every weekend. This incredible workforce crisis. It's really been a moral and societal failure, I believe, in terms of the human service workforce. That it was more than a crisis before the pandemic started. There was an unwillingness and an inability of our society to really focus on the human service workforce that's taking care of our most vulnerable citizens. But we'll talk a little bit about that. Workforce always keeps me up. To add to what Richard said, I think much more focus on prevention, right? Those upstream areas in the system and those health-related social needs. If we put our money where our mouth is, we'd be spending way more of our resources around food insecurity, housing, transportation, all mental health care, as Richard mentioned, behavioral health care, which we know and we have seen impacts quality, outcomes, and cost. We've seen great example. I wish Dr. Gruber was still on the phone. I wanted to sort of come back to the value-based, and we'll get there a little bit later, I think. But I have seen, and we have seen some improvements in cost, quality, and outcomes as our system has moved toward value-based care and more capitated arrangements in our system. But we need to focus more on wellness and prevention, beginning at a young age. There's a lot more that we need to focus on, but those are the things that are sort of keeping me up.
Got it. Lisa. How about you?
Yeah, thank you. I mean, there's clearly a bunch of competing priorities when you talk about this, and both Richard and Ken have already talked about, I think, the things that are top of mind for a lot of people, which are the workforce issues, direct service workers, mental health workers, nursing. As a nurse, I know I'm in that population of nurses that's starting to age out, and the silver tsunami is going to happen in nursing, sometime between now and the end of the next 10 years. And I don't think we have a good plan for how we're going to, fill that gap. And I think the pandemic exacerbated that in grand fashion by, sort of pushing some healthcare workers really out to retirement. And, they basically just said, okay, I've had enough of this now. And so I think, it's accelerated our issue around workforce and workforce sustainability. And it's a problem that we're actively thinking about. Access to care and health equity really are two things that completely, were also exacerbated during the pandemic for a number of reasons. I think we saw, how, communities of color, lower socioeconomic communities, and other underserved populations were greatly affected in a much grander way than others by both COVID infection, mortality, and morbidity rates. And we haven't solved for that. That's something that we haven't really, done a good job of, and we need to keep focusing on. The mental health crisis was a crisis before the pandemic. It's certainly also been exacerbated by that. Solving, access to care, not just for, both in places where people can be served, but also in the pipeline of people who are qualified to care for those individuals. In the access and health equity space, I don't think, like on a routine basis, we think very much about how important our public health system is. And we learned during the pandemic how very vital it is to reach those communities, particularly Black and Brown communities, who don't always take advantage of the traditional ways that we deploy solutions like vaccine availability. So reaching them in the communities that they live in became very important. And I think, understanding that, particularly in the state of Massachusetts, local boards of health are resourced in different ways, and it varies from municipality to municipality. Strengthening that system so that we, are always prepared for more even responses across the state, I think is a really important thing for us to continue to think about as well.
Sounds good. So as the only gray beard on the call, I'm going to hand over the moderator responsibilities to the full red bearded editor of the Worcester Business Journal, Brad Kane. So Brad, you can take it from here. Thank you.
Thank you, Peter. So Ken, now it's your turn to go first. And I'm going to jump on to what kind of Lisa ended up with, which is disparities in the healthcare system, which obviously have been greatly exposed by the pandemic, but were long existing before it. How do we fix it? How do we address it?
Yeah, wow. It's good to see you, Brad. I think, again, I'm hopeful, right? Growing evidence has shown that I think if we identify and help people with these health-related social needs like homelessness, hunger, exposure to violence, we can, and we are seeing an improved outcomes and lower cost. I think one of the things we have to do first is to acknowledge and accept that as a society, as a system, the importance of the health-related social needs and holding ourselves accountable. We use that word, accountable care, but holding ourselves and the system accountable to that and measuring our impact. I think specifically our system needs to do a much better job at screening for health-related social needs to help inform what the patient needs, what their treatment plan needs to look like, and to work with the community services, the community itself, to help those individuals address those health-related social needs. And I think this idea, not more than an idea, but the value-based payment, the relationships between health plans, providers, and community partners is critical. And we've begun to see in our state over the last several years, and the ACO initiative, we've begun to see those relationships and partnerships begin to bear fruit. For instance, in some of the relationships that we have with our local health centers, we've seen improved outcomes now because we, as a human service organizations, we're getting claims data, which we've never gotten before. So we can look at the cost impact, the cost of the interventions that we are providing in partnership with our sister agencies. But we've seen in 69 individuals, for instance, in a cohort with the health centers, a 32% decrease in costs. 32% decrease in costs from $1 million to $700,000, and that does not include the substance use costs. So we're beginning to see really excellent outcomes and decreased costs as we move down the value-based payment ladder, if you will, or up the ladder.
Well, thank you, Ken. Richard, same question. It's really simple answer, I'm sure. How do you fix all the inequities of the healthcare system?
Well, Brad, in my 20 plus years working in this field, I have never seen as much attention to this problem as I've seen right now. And the problem has existed for really forever. So I think the number one thing is that we take advantage and not miss this moment when so many people are talking about health equity and disparities in the delivery of healthcare. I think the solution, it's going to be difficult to address because it's multifaceted, but I do think that we need to take a systemic approach to health equity. It's probably our best chance at dealing with it. As I said earlier, in Massachusetts, quality in healthcare is considered table stakes. And if you are a high quality organization, there are a number of ways in which that is measured and reported and publicly known. And if you have areas where you need to do better, you know what those areas are. And I think we have to bring the same approach to health equity. So for example, the state is submitting very soon its 1115 waiver to CMS. So what that is basically is a proposal that the state makes to the Medicare Medicaid agency around giving it flexibility in how it spends federal dollars. And as part of that, the state is going to be emphasizing the importance of health equity and addressing that. I think that's the way to do it. That will be a much more systemic approach. In my field, in health insurance, our national accrediting body has just launched a health equity accreditation proposal. So basically, if you're in the health insurance field, you can apply, and if you meet the standards, our agency is called NCQA. If you meet those standards, then you are accredited as an organization that addresses health equity. And I think that kind of systemic approach is the way in which we're going to be able to make progress. Clearly, it's a real problem. And the other thing is, I think Ken referred to this, there's much more known right now about where the disparities are in healthcare. The Massachusetts health plans are collaborating and funding a study that's being done by Harvard on measuring health equity and disparities in healthcare in Massachusetts. Their initial findings were just reported out. There's a lot more work to be done, but clearly, if you are, a senior, if you are low income or a minority, your access to telehealth, I think we're going to talk about that in a little bit. Your access to telehealth is much less. You use it much less than others. And I think that's an example of a disparity in healthcare that is being exposed and needs to be addressed.
I'll toss it to you next. Oh, I'm sorry. Lisa, I'll toss it to you next.
Oh, thanks, Brad. I agree with both Ken and Richard that this is a problem that we've been dealing with, and is continuing to be very gnarly. But Ken talked about accountability in kind of this endeavor, and one of the ways to make sort of hold people accountable is to make sure that we have accurate data and that it's transparent and available. And I think we began to use data in a much more facile way with really almost immediate access to data around the COVID-19 infections and so forth. So we need to translate sort of the way that we collected, used, and socialized that data in a more broad way so that we can address things around health equity and disparities. So I think the facilitation of that is really important. The relationship between social risk factors and outcomes, I think, is long been understood to be important. And I think we need to continue to sort of zone in on those things so we can address some of those, those issues that create the inequities. The other thing that I think we need to continue to advance our work on is sort of understanding the cultural impacts of why people do or don't have access to care, because it's not as simple as, if you build it, they'll come. And Dr. Gruber talked in his discussion about one solution to at least providing health insurance that might improve access is for those people that file their taxes and indicate that they don't have health insurance, just enroll them automatically unless they indicate they don't want to be. Well, that works fine for people who actually file taxes, but it doesn't work fine for all the people that don't, for whatever reason that is. So I think we just have to keep looking for those solutions.
Great, thank you. So I should have it noted for the record, I wrote this question, this next question before we learned of the Omicron variant. But Lisa, I'm actually gonna go right back to you. So we started off on a positive note with this Q&A, so let's keep it positive, and then let's say that vaccines are still somewhat effective against Omicron. Where are we at with vaccines? Let's put on our Dr. Fauci hat. Sort of what's the next step on that? And I guess the big question is, is herd immunity achievable at this point?
Yeah, those are all really big questions. I think that first of all, it's really important to clarify what herd immunity is, so that everybody's on the same page with that. And herd immunity is protection from an infectious disease that occurs either from, when a significant portion of the population is either immunized against that disease or has had the disease and had natural immunity from that. And in the case of COVID, it's going to take about 90% of people to be either vaccinated or developed antibodies in order for us to really consider herd immunity, possibility. But while Massachusetts, I think, has done, better than most, if not all, states in the distribution of vaccine, about 70% of the population in Massachusetts is vaccinated now, which is, is really, really positive. But just Massachusetts isn't a bubble. We live in a country that, people move about the country pretty easily. In fact, they move across the globe pretty easily. So managing and getting to herd immunity isn't a simple equation of fixing things in Massachusetts. They're doing a good job here. It's really a matter of attacking the disease globally. And we know that globally we're a long way off. So, the emergence of another variant like Omicron is an example of, variants happen when the virus is transmitted from one person to another. So the way to stop these dangerous variants from emerging is to try to slow or stop the transmission of the disease. That obviously occurs through vaccination, but also occurs through using some of the other measures that we've known to be effective up till now: hand washing, social distancing, masking, and so forth. So to the extent that we can slow those processes down, we'll continue to stop, the spread and the evolution of the virus. The virus is like any other living thing. It's, it tries to survive through reinventing itself when it realizes it's being attacked by things like vaccines. So I think we need to continue to stay vigilant to those things. And I think there's an implication globally for cooperation amongst countries that can to help, create a more even distribution and availability of vaccines in some of the underserved countries so that we don't see things like this happen. This morning's news, I think there is the new variant has been detected in, I think, 21 different countries. So it's spreading rapidly. It's an implication for us to just go back to the discipline that we've used that kept us in the place that we're in today.
Ken or Richard, anything you want to add on about vaccines in general? I don't know if you want to talk about global health or just something more specific to your areas of expertise.
I think, go ahead, Richard.
Oh, all right, thanks. No, I don't have anything to add other, I certainly defer to Lisa as the clinician on this this call. The only thing I would add is, I think it's important to Lisa's points about the number of people who are vaccinated and the need to get more people vaccinated, that we encourage the vaccine and take advantage of our positions as business leaders to encourage those who we work with to get vaccinated for the good of themselves and the good of the society we live in.
I would just echo with the new variant, right? I think the healthcare system has been traumatized since the beginning of the pandemic, and it feels in some ways like we had come through this, and now it feels like we are gearing up for another re-traumatization with this new variant. And I know with my workforce, my 1,200 plus workforce, my focus is on trauma-informed, becoming a trauma-informed organization. So I'm generally very concerned about the new variant and worried about the workforce and its implications on the people that we employ.
I could add one more thing too, Brad, because there's a lot of discussion. In different places you hear discussion about why do we need a booster if the vaccine was so effective? Well, like many viral flu is another example. We get a flu shot every year because we're vaccinated against the flu. Your optimal protection period is in 6 months post your vaccination. The same thing is true with COVID, and it's also true that there are multiple strains of COVID, or variants as we're calling them now, that will continue to emerge for the reasons we've already talked about, which is why boosters are important. So it's not just making sure that people who haven't been initially vaccinated are getting vaccinated. It's the people who are 6 months out from their initial vaccination to get boosters and continue to boost their immunity against this. I do think that COVID is going to become a part of life, just like flu is, and we're going to get better at managing it and preventing disease. But getting people sort of in the right headspace to understand that and to just sort of transition to this approach where we are accepting it as a part of our the way that we need to protect ourselves just on a regular basis, I think is going to be really important.
Just another quick comment with regard to vaccine with our workforce and my workforce at Open Sky. We have such a tremendous shortage. We have over 250 vacant positions in my organization today. And with my sister agencies just in Worcester County, we're talking thousands of vacancies. And so putting a vaccine mandate into place in our organization runs the risk of 1 or 10 or 100 people leaving my organization and leaving our organization. And so that balance of public health and a mandate with the safety and services provided every day and to thousands of people it's a real challenge. It's one of the greatest challenges we've ever faced.
You're 100% right.
Well, let's expand on that a little bit more too, because obviously healthcare worker shortages and healthcare worker burnout was a problem well before the pandemic. I think we did a report back in 2019 showing that like home health aides was going to be the biggest job openings and the biggest vacancy rates in all of the state, just heading into the next 10 years. And that was before the pandemic. Now you hear anecdotes and reports about just how bad healthcare workers are getting treated by patients, and all the skepticism around science and health. And Ken, you're talking about managing your workforce and just keeping people happy and healthy, which is just especially challenging. But I guess simply, how do you address burnout, and how do you just keep people who are up against a traumatizing fight?
Right. Yeah. Again, that's the thing that keeps me up is how do we keep our workforce engaged and healthy so that they can provide great services. It's our biggest challenge. The human service workforce, I like to refer to them as sponges, and healthcare human services people as sponges, right? We soak up all of people's illness, crises, all of their problems and their needs. And it's really important that we take the time, and as employers, that we put in place systems that take the time to sort of wring out that sponge, right? We need to be sure that we have the systems in place, that we're taking care of our employees. And at Open Sky, what we're doing is we're focusing in two significant areas: race equity and becoming an anti-racist organization, and becoming a fully trauma-informed organization. And we believe that by transforming our organization around those two areas, which, by the way, are completely aligned, that we will provide better care in the end, but that our employees will be better engaged and focused on our mission. So those are a couple of ways that we're addressing this burnout at Open Sky.
No, if I could add to what Ken said, at our organization, we also have many, many open positions. Some in the area of direct care workers, such as Ken's area, but also in areas like customer service and claims processing. I think we're experiencing what many businesses are experiencing even outside of healthcare, which is it's very, very hard to recruit and retain workers right now. And there's probably a number of reasons for that. But what we're doing is, first of all, we have to make sure that we can pay fairly. So we're constantly looking at our benefit structure and our pay structure to remain competitive. We also have to support our employees who are now working mostly in a hybrid environment. So one of the things that we've done is we provide training for managers, because managing someone in an office, which is what we were doing before the pandemic largely, and managing a workforce in a hybrid mode is something very different. And how do we keep employees who aren't in the office every day talking to each other, socializing? There's so many parts of coming to work that are support work, but they're not about work. I mean, they're just about being human and meeting with your colleagues and talking and enjoying the company of your colleagues. And many of those things are gone now. And I think we've had to adjust, and other companies like us have had to adjust to that and support our employees in a different way going forward. I think it's hard for many people to work from home. At the same time, we know that many of our employees have become used to that, and they've built their new work life around that flexibility. So it's going to be interesting in the years ahead as we move, and I'm hopeful that we will move past the pandemic, and what will work be like in the future. And right now, I think we're more on the side of remote, at least in my company, and I think that other companies that can do that. If you're not in if you're not in direct service, But that may swing back as people begin to see, they want to be around each other and they want to be engaged with their colleagues. And it'll be interesting to see what the future holds for work and how people work.
Yeah, and I'll just add, we talked about this a little bit earlier. We had a workforce issue before the pandemic hit, and it's been exacerbated certainly by that. And, for companies that can work remote, I think, Richard and Ken have both, highlighted some of the things we have to think about. How do you create, job satisfaction in a new and different environment? And I think we're continuing to learn about that. But for, healthcare workers who have to be physically present to deliver care, a whole host of things, need to be, I think, thought about. So, as a nurse who's been in direct service, we've been talking about, having resources and staffing and availability and, wage issues for a long time, which has, always contributed to, the difficulties we have around recruitment. And it's far worse today. Making work easier for the people that are providing care. And what I mean by that is, making sure that the resources are there for them. Not just the staffing, of course, is important because they're already stretched in ways that we never imagined, but supplies and, ancillary services that make their work easier. And I think will help us to sort of help them to stay present and wanting to continue to do the work. Nurses in particular are aging out, because of the average age of nurses in Massachusetts is, in their mid to late 50s at this point. And we don't have a big enough pipeline. And that's an issue of concern that's really been being addressed really, in, not only in our state, but across the country. But in Massachusetts, we're in the process of standing up a Center for Nursing Workforce Sustainability. The Commonwealth Medicine is engaged in, along with the Executive Office of Labor and Workforce and Executive Office of Health and Human Services. And at least on the first blush, we're looking at needing to deal with issues around, the academic aspects and the curricula that are attached to nursing. How do we create enough availability of seats in nursing programs? How do we have enough clinical placements to actually serve the number of nursing students that we have across the state? Those are real issues. And healthcare systems that are already stressed, it's not easy for them to provide, worthwhile clinical experiences for students so that we can properly prepare them to come into the workforce. That's sort of a root cause problem that we need to really address. And we could probably talk about this forever, but I think we've hit on the most important points.
And if I could just add really quickly, we could talk about it forever. In human service area around workforce pipeline, in Worcester County, we're working with several sister agencies and really rethinking those barriers, some of which Lisa mentioned, to folks entering the field of human services and mental health. And we are sort of intentionally supporting entry and advancement of BIPOC and immigrant and refugees through the use of career support navigators. So this is a really cool idea, I think, is that we'll be looking at a cohort, we'll be studying this, but supporting individuals that are working on the direct line with their own health-related social needs, childcare, transportation, getting their car fixed so that they can drive to work, having navigators help people with that, and the navigators will help them advance their career at the same time, helping them with certifications and training and educational programs that will help them see human services and behavioral health as a career, and starting early in high school, right on through and partnering with our universities. So we're really excited about this work around pipeline.
Yeah, I think another sort of related thing that we need to think about is that we don't do a good job of providing sort of real-time emotional support for our healthcare frontline workers. It was almost non-existent pre-pandemic. It's starting to emerge a little bit, but really not in the form or fashion that's necessary to really kind of keep our healthcare workers healthy and able to continue to work, and also encouraging, self-care, which healthcare workers in general are not very good at, speaking from my own experience.
Great point.
Just a quick, I guess, programming question for the three of you. I know we're scheduled at 10, and we want to be respectful of everyone's time, including the audience members. But we are having, I think, a pretty good discussion and a couple of other topics we want to touch on. Is everyone good if we go over maybe like 5 minutes? Not 20, but like, let's say between 5 and 5.5 minutes.
Yeah.
Great.
No problem.
Well, if you need to jump off, let me know. But I think we're transitioning to something we were talking about with Dr. Gruber as well, which is about telehealth. Lisa, I think you mentioned that the pandemic just certainly took the entire healthcare industry and just threw it, say, forward. Maybe 5 years, 10 years. But from where we're at with telehealth, where we are now, like, how does it become just a more regular part of the healthcare system? Like, are we there already? Is there something that we need to do to ensure that this keeps going, or are there parts of it that we should seek to lose that maybe aren't working as well? Lisa, I think I'll start. No, actually, let's go. Richard, I'm going to put you on the spot because I think you have the not speak in the longest amount of time. So let's toss it to you first, but then open up to everyone.
Sure. It's a good topic. And I think your way of describing it was right, Brad. It's really was pushed forward as a result of the pandemic. And it's here to stay. And I think that's a good thing. I think one of the things that the state of Massachusetts did early on in response to the pandemic is it mandated that a telehealth visit be reimbursed at the same level as an in-person visit. And I think that was a good thing because it sent the message that a telehealth visit is a true medical visit. Now, it's not appropriate for all things, obviously, but that it can be a very, very appropriate way to be seen by a clinician. So I think it's here to stay. I think we will see more of it going forward. We certainly know that there are some organizations that are offering essentially a health insurance option, which is built around virtual care in the first instance. And I think it'll be interesting to see how that develops. I think we've been talking for most of this session about healthcare workforce shortages. And if you think about it, in Massachusetts, there is a genuine shortage of primary care physicians. Lisa talked about the shortage of nurses. That has to be addressed in new and innovative ways. And I think telehealth will be one of those things. My impression also, Brad, is that telehealth has been and holds a lot of promise in the behavioral health space, that many people took advantage of that. Clearly, there is a real need for behavioral health services. There was before the pandemic. It's even grown since then. And I think telehealth will be part of that future. So I'm very optimistic that we will use that as another digital way to bring healthcare to more people. It also relates very much to the issue of healthcare disparities, because not everyone equally across our Commonwealth access telehealth. And so I think we need to look at that as we're looking at healthcare disparities to ensure that, for example, elders did not access telehealth to the same degree as those who are in the workforce or those who are younger. That might be just a generational thing, but it might not. There might be more to it. But I think telehealth for elders is something that I think can really hold a lot of promise going forward in not only bringing healthcare to people in their homes, but also as another way to combat isolation and other, social determinants of health.
I'll jump in if that's okay. I think, Richard brings up some really important points. And I think, the real barrier, we've always had we've had the technology for a long time, right, to do telehealth. It wasn't widely used for a number of reasons, most of which Richard has already talked about. And, I think probably the biggest one was either inadequate payment or lack of payment completely by third-party payers, which I think we've kind of gotten over that hump. And it's worked well in a lot of situations. But, like the older adults, a great example, we don't really know the reason why they're not using it as widely. And it's an implication for us to look at and understand what kind of other adaptive technologies we need to develop or deploy in order for them to be able to use it successfully, if that's possible. The other population that, isn't able to take advantage in the same way as others is, the lower socioeconomic communities where, homes that don't have technology available to them, there's no internet, there's no computer. I think that kind of harkens back to the comments that I made earlier around figuring out how we engage and support and bolster our public health system to develop solutions for those populations of people across the Commonwealth and across the country, really. But there are some related, I think, issues or thoughts that we need to consider around telehealth, because, and I think it was, we started this conversation when Dr. Gruber was making his remarks, but the notion of making sure that we're engaging healthcare professionals to the level of their licensure or capabilities, using, home health aides for certain types of work in the home that is, has been challenging when you're crossing, state practice acts and things like that. Advanced practice providers who could provide telehealth services, the issue of providing services across state lines and reciprocity. And, there's the Nurse Licensure Compact that Massachusetts hasn't yet jumped onto, which obviously has pros and cons, but I think we need to really, we have to ask those hard questions and deal with those things rather than kicking the can down the street on those.
And to add, incredible improvements in access. We're able to use telehealth, helping people coming out of jails and prisons. So we're able to connect with them while they're in the jails and the prisons or on a reentry plan, and then connect with them through telehealth when they're coming into the community. So incredible advances in access. I also just want to raise this area around workforce. I think Richard touched on, we want to be a little bit cautious because in terms of the workforce, we've got a host of social workers, right, who can go home, work from home, and see clients through telehealth. And we have lots of folks, seniors, kids, and families who want to and are demanding to be seen in person. And if a clinician can work from their home, earn more money, see more people, and keep their slippers on all day, it creates a real challenge for the workforce in terms of recruiting and having people come to an office or go into a person's home. So we need to be careful and keep our eyes on that.
Yeah, that's a really good point. Actually, for almost everything we've talked about, there's always some sort of balancing effect that we need to, make sure we understand the consequences of.
And I think we're kind of at maybe our last question, or maybe one of two. But one topic that I think we've touched on a lot, but maybe haven't dived into explicitly, is mental and behavioral health, whose needs, I think, Ken, I think it was you that said at the beginning that, we're certainly talking about it a lot more, but there's still a lot of needs out there among a lot of populations. I guess, how do we get our arms around, or really what's the next step? Ken, and I'll start with you and then open it up to everyone else.
The next step is, I think later today, I'm speaking to a few legislators and trying to continue to get them to fund our services, release those funds we need. But I think in terms of our legislative advocacy, we need to make sure that our legislators understand the importance of mental health and the funding of services for direct care staff in particular. Increase the number of people making a career in mental health and earning livable wages. I think stigma, we need to continue to address stigma. Parity, we're not there. We're not there. We have a long ways to go with regard to parity. Focusing on prevention, and finally, I think access, just really looking at innovative ways to improve access, yeah, so there's a lot that needs to be done, areas we can focus on.
Richard, Lisa, I'll let you run to see who can go first.
Yeah, I think we've talked a lot about this already. I think, mental health workforce is, sort of one of the three focus areas that the statewide workforce collaborative has been focused on for a number of years, at least the last three, in a much more sort of organized way. And for the reasons that Ken has already identified, we know that we have shortages and they're related to, pay equity is a huge issue, I think, in the mental health space. It's very hard work to begin with. And if we can't compensate people appropriately for doing that work, why would anybody want to do it? It's emotionally exhaustive and takes a toll on the caregivers. So I think, focused efforts that include, sort of state and federal government, inputs and supports are going to be really important for us to be able to address this in the future. I think that's why, sort of convening a statewide, caucus of people that can actually have influence over this stuff, both through, both in practice, policy and regulatory arenas, I think are all going to be really important to pull those things together so we can try to, in earnest, try to tackle the problems that we know exist.
Yeah, I agree, Lisa, with Lisa and Ken. I think we need more people who choose the behavioral health, mental health field. And I'm quite sure that we need to invest more in those fields so that people who are doing this very difficult work are being paid fairly. I also think, and this is, my colleagues may not agree with this, but I think that if you are, we ought to consider at some point that if you are licensed in the field of behavioral health in whatever capacity, that as a condition of that, you need to also see individuals who are on Medicaid, because part of the shortage in the behavioral health field is that many of those who provide behavioral health services don't see Medicaid patients. And there's reasons for that. They're very busy. But if we can get more people into the field, I think everyone ought to see everyone.
No, you're not going to get an argument from me.
Yeah, you got that one right. Cool.
So we started this Q&A on a positive note, asking you all to identify what have been the optimistic parts of the healthcare industry that you've seen. So I would like to end on the same positive thought, which is the end of COVID. Now, as Lisa alluded to earlier, like it's not going to be like one day, president's going to come out and declare, hey, we defeated COVID, and we all go out for ticker tape parades. But instead, it'll probably be something that's incorporated into our lives, but maybe less so. So I think the question I'd like to end with is not necessarily when will COVID end, because it's asking you to predict it, but when will it be, in your looking into the crystal ball, which is impossible, when will it be a less intrusive part of our lives? And then what do you see for the future moving forward? What excites you about healthcare?
So I'll start. I think the key to it being less intrusive is controlling the spread. So the things that we've already talked about, like it's really, now is the time really for us to try to get the upper hand with it. And I don't, we've done a really good job, but there's still, ways to go on that. And I think we keep getting reminded of that every time a new variant pops up. And we realize that we haven't really effectively learned how to stop it. Well, actually, we know how to stop it, but we have to be able to deploy the solutions much more evenly and effectively across the globe. there's research out there that says that, a pandemic, start to finish, lasts somewhere in the neighborhood of about 5 years. We're into the beginning of the third year now of this pandemic. We have to hold the line, I think, and continue to, let the science drive the solution, and, continue to work on vaccinating and the preventative practices. I mean, some of why we're seeing the emergence of new strains now is that, both, it's sort of multifactorial, immune status of people who were vaccinated early on is starting to wane a little bit. And if we can't deploy the booster as widely as we did the initial vaccines, we're going to continue to see breakthrough infections, albeit, we know that breakthrough infections in immune people are less severe, and in vaccinated people specifically, the breakthrough infections are not killing people, which is really the most important thing. But I do think we will get to a point where it goes from pandemic to endemic, and we're just, it becomes a part of, our life, like the flu that we manage on a seasonal basis, like everybody else does. But we just, we're all exhausted from this whole thing, healthcare workers and regular citizens alike. So keeping, sort of our focus on getting the upper hand is really what we need to do. And I think we can.
Yeah, I'm optimistic. I agree with Lisa. I like what Lisa said about let science provide the solution, and I remain optimistic that that if we do that, we're going to be okay as a country. I mean, this is a pretty. I think one of the themes of this discussion has been we started about the resilience of our workforce, but I think it's the resilience of our community. It's very real, and I have a lot of faith in our scientific creativity and innovation, and I remain very optimistic.
I'm not going to go the other route here. I have to stay true, since I think, how do we recover from trauma? Recovery from trauma is possible and happens every day. We have to remain hopeful for our communities, for people in our communities, for our workforce, for our employees. I think we have to support one another. We have to look out for each other, and we have to have each other's back. So I too am hopeful. We have to be intentional also as we recover from this trauma. And that, again, that means looking out for one another. And the impact, I think, as we begin to see the rates head in the other direction, the mental health system, the isolation, the suicide rates, the rates of overdose. There's lots of ways that this has impacted our communities. And I think we'll see some of those trends moving in the other direction.
All right, I think on that note, I'd like to take this moment to maybe end our discussion and thank our esteemed panelists, Lisa, Richard, and Ken. And of course, a big thank you to our keynote, Dr. Jonathan Gruber. This was a really insightful conversation and just a great forum overall. And thank you for your contributions. Special thanks again to our presenting sponsor on this annual event, Fallon Health, our corporate sponsor, Always Health Partners, and our media partner, GBH. And just a reminder to our audience members that we will include a link of the recording of today's session in our post-event follow-up email. So thank you again, everyone, and have a great day.